Okay, guys, let's spend a little bit of time talking about what is essentially a complication that can happen with with elbow injuries. And so sometimes they have to do surgery for this problem, but this problem doesn't usually happen on its own. It's called heterotrophic ossification, and it primarily occurs in the elbow. So basically, what this is, and I'm guessing if you've seen any patients who've had elbow injuries and they're really, really stiff, you've probably seen this. And you maybe didn't even know it's what it was, but this is what it is. And basically, what it is it's a formation of extra bone. It's like a mature bone that grows where it's not supposed to grow in the soft tissue. So possibly in tendons, but also just in muscle around the elbow. And basically what it happens is the cells all of a sudden these progenitor cells all of a sudden exist in the wrong place, and so nobody really knows why it happens. And what's weird is it really happens mostly just in the elbow, and for some reason this extra bony growth occurs around the soft tissue in the elbow. And unfortunately what it can lead to then, obviously, if there's extra bone, it can lead to contractures. It can lead to so much bone that the bones start fusing, or we have what's called bone bridging. And so this can be a big problem, and it can lead to, obviously, a lot of complications at the elbow. So it tends to happen in patients who have had some sort of direct trauma to the elbow. So with elbow fractures, 37% of them can develop heterotrophic ossification, this extra bony growth, which is a huge amount. I mean, that's more than 1/3 will end up with this problem. Sometimes even if you just hit your elbow really hard and there's bleeding internally or bruising internally but no fracture, you could end up having this ossification. If there's burn injuries, really bad burn injuries can end up with ossification around the elbow. For some reason, head trauma can lead to this ossification. And then spinal cord injury, and they think this is usually because of the lack of movement at the elbow or other things that somehow cause this change in bony, this process. So unfortunately, over 20% or about 20% of people in any of these groups, except for elbow fracture where there's more than 20%, can develop HO. So oftentimes this becomes more of a problem than the original injury. So sometimes the actual injury of the elbow, so like if you look at this x-ray here, the fracture of the elbow, not a good fracture, right? But if it was just the fracture, we would be fine. But if you can see on that picture on the right, there is significant extra bone that's grown in there. And that is where we have a lot of problems. That's where we end up with complications and lack of mobility. And you'll see it can also affect other things like the nerves around the elbow, muscles around the elbow. So the injury itself might not have been a big deal, but this ossification becomes a big problem. So it tends to be diagnosed with a bone scan. Yes, an x-ray will work, but the problem is an x-ray sometimes doesn't see it very well. But especially with elbows, if they're getting some sort of bone scan or imaging regularly, then you can really hopefully figure out whether or not the ossification is going to become significant. So what they found is even 2 weeks after some sort of injury or surgery, if the x-ray starts to show a little bit of extra growth, then hopefully you can catch it early enough to recognize it and hopefully not have to end up having another surgery for the ossification. And you can sort of treat it conservatively. The problem is that things like swelling and pain and significant mobility deficits don't usually appear until 8 to 10 weeks after an injury or surgery. So you can't count on those things as being the way that you figure out whether or not they have ossification. Again, and the problem is these patients, they're immobilizing them after a fracture, right? So you have an elbow fracture, you're immobilizing them, so you don't realize that they're getting ossification because you're not doing a lot of range of motion, and so you're not recognizing the problem early enough, and so the ossification can end up pretty bad. Some predictors that can help us figure out if they get ossification, one of them is the time between the injury and the surgery. So if for some reason you have an injury and you don't end up having surgery to the elbow for, let's say, 4 weeks, then you're more likely to develop ossification. That could be definitely part of it. And then obviously the longer time of, that should say, longer time before they actually mobilize after surgery. So if you're in immobilization for long periods after surgery, that would be another predictor of the fact that maybe there's some ossification occurring. So you want to get them moving fast. Oh, big surprise. Moving fast but gently, relatively early. So you're less likely to have this complication. Because this complication can lead to different kinds of pain, non-operative or conservative treatment is going to include some medication to help with pain. Again, around the elbow, if you're getting bony growth, you could affect nerves. And so remember the ulnar nerve moving through the ulnar groove, median nerve going along the anterior aspect, and the radial nerve going along the extensor tendon of the elbow. Any of those are relatively close to soft tissue, and if that soft tissue gets bony growth, you can affect the nerve. So you take medication to help decrease irritability of the nerve. They might also do radiation, and then we try to do range of motion exercises, long-term stretching exercises, whatever we can to release any muscle contractures, to try to get as much mobility as we can. So, and we're trying to do that in as less irritability as possible. So what they have found is that if you're doing range of motion with patients who are not having surgery but do have ossification, you need to make sure you're checking in with the patients regularly to make sure that they didn't have significant amounts of irritability after your treatment. So you can be relatively aggressive with them, but you don't want to increase inflammation. You don't want to increase the possibility of getting more bone, more ossification. So it's really important that you're communicating with your patients as you're treating them with stretching and range of motion, to make sure that, they might be a little sore afterwards, but they can't tell. You don't want them telling you, oh my gosh, I was sore for like 3 days and I couldn't move my arm for 3 days after your treatment. That's not good. Even if they're saying they couldn't really move your arm the day after your treatment, that's not good. You probably overdid it. So you want to try to find that happy medium if you're doing non-operative treatment, to try to improve range of motion without increasing irritability. So if it's significant range of motion loss that's affecting their ADLs, they're going to probably consider doing surgery. And they're going to wait to do surgery for this until at least about 6 months after the injury. So they're going to wait. And that picture shows this poor person has some different weird ossification problems, including in their elbow. But they want to be somewhat conservative before they go in and try to remove that bone. And they really want to make sure, theoretically, that the bone is mature, that the bone isn't soft, because it's going to be harder for them to get it out. So this is bony growth that's happening in muscle. They really want that bone to be really distinct and obvious. They can just go in and essentially cut it out. And they have to be very careful with nerve, because again, this will happen around nerves, and so they have to make sure that that they're careful around the nerves. And they're usually going to choose to do surgery if there's some nerve irritability or something related to the nerve. So like if they're complaining of MAMU, if they're complaining of numbness, tingling, or anything like that from their elbow down to their hand, that would be another reason why they might choose to do surgery for these people. So to get in there, they're going to usually dissect the tricep muscle. They're going to pull it off from the posterior humerus. And then from that area, they're going to look at that posterior capsule. And again, the bone is usually around the olecranon fossa. So I kind of showed that picture earlier. That's usually where it is. And so then they will take that out. Usually that's where the bone is. So that's where they come in as posterior. But sometimes they may have to go in more medial or more lateral, depending on where the bone is, to be able to get to it. And as I said, this happens a lot with burns. And so if it's happening with the burn, then they have to be careful, with the scars of the burn, how they go in and do it. So the scar could be almost, the surgical site could be almost from anywhere around the elbow. Because this is essentially a complication from another surgery a lot of the time, you're going to have complications from this as well. Okay, so the body is not responding to things very well. There's a high percentage of complications from this surgery of bone removal. So recurrent, so this coming back, ossification coming back is very, very common. Also, the possibility of not being able to get full range of motion, even though they got rid of the bone, so they got rid of the thing that's causing range of motion issues, you still may end up with range of motion issues. So that's the hard part, is if you're working with these patients and you notice and you have them do an x-ray and they find this ossification, you say, oh no, and you guys work together for a long time and it doesn't get much better. And the doctor says, okay, it's time and it's appropriate for us to do surgery. They go in, they do the bone removal. The patient's expecting to get full range of motion because they removed that bone. And most of the time, well, at least half the time they don't. And in this case, they're saying failure to achieve functional range of motion. So it's, functional range of motion, meaning that they can bring their, bend their elbow enough to be able to do their hair, or get their hand behind their back, or extend the elbow enough that they can weight bear on that side with their hand. Those are the kinds of things that they mean by functional range of motion. And unfortunately, a lot of these patients aren't going to get it. So, especially the worst outcomes happen in patients who have had a burn, or something like that. So just keep that in mind. If they're just somebody who's had a fracture, they might have better outcomes. Again, other complications could include continued problems with the nerve, or an infection, or if it's an issue where it's around something like the MCL, the medial collateral ligament, it could actually lead to a rupture of parts of the ligament. So again, you're not going to see this surgery very often. It's really important that the doctor makes a good choice to do the surgery. You're probably going to see this more likely as a conservative treatment of trying to get range of motion with ossification. If the patient has a really hard end feel, so like, anybody who's worked with elbows for a while, that with flexion, you should not have a hard end feel, right? It should be soft. There should be like bouncing when you do flexion. If you're doing flexion with the patient and it feels like you're hitting bone, there's a possibility that they have ossification. And so I would certainly suggest taking them to go get an x-ray to see about this ossification. And then again, you may continue just doing conservative treatment, but if it's bad enough and it's been long enough, like again, 6 months after an injury, then a doctor may choose to do surgery. So if they do surgery, the first couple weeks are really, really pretty conservative. The first 2 weeks or so, we want to make sure they don't get an infection. We want to make sure that there's no stress on the surgical site. So the goal is that we want their passive range of motion to try to be within 80% of what is allowed. So when it says available structural limits, depending on what they were able to remove in terms of bone, or in terms of if there was hardware there from a fracture, any of those kinds of things, The structure of the elbow itself may not allow for full flexion or full extension or both. So you just want to get within 80% of that in the first couple weeks if you can. And then just like with other things, we're focused on the elbow, but you need to check the shoulder and you need to check the wrist. Make sure that they have full range of motion as well. So our patient education, a lot of times with this one, doing continuous passive movement is helpful. You want to keep it moving, but gentle movement. You don't want to cause trauma to it, just like with the non-operative patients. You don't want to increase the possibility of irritability or inflammation. And so passive range of motion, continuous passive movement, CPM, can be really helpful for these people. As we've talked about before, I think with CPM, you need to do it for hours a day. So that can be really annoying for some patients. You should start it as early as possible. So this says day 2 and continue for up to 6 weeks after the surgery. So really do it as much as you can, as long as they can tolerate it, as many days as they can tolerate it, as many hours as they can tolerate it, and make sure it's gentle, that it's not causing an increase in pain. They need to also monitor where the surgery was. Everybody needs to check that to make sure there isn't infection. And then, of course, they're going to have to change their movement patterns for a while so that they don't cause irritability. And treatment, like I said, CPM, 3 to 5 days. Well, we said 2 days post-op, up to 12 hours per day, which just makes me laugh because nobody's going to do 12 hours per day. But you want to do as much as you can, as long as you can. And then you're just doing active range of motion at the wrist and hand and the shoulder. You can do passive range of motion as a manual therapy as well. You just have to be really gentle. So that's why they say CPM for the first couple weeks, so that it's just a very, very simple, gentle, passive range of motion. From weeks 2 to 8, this is when we can start doing a little bit more, but we still are going to probably see pain with these people. They're probably going to have some swelling, some redness, some irritability. So we really need to do modalities and things that will help to decrease that. We also need to do manual therapy for the scar to make sure the scar is okay. And then we want them to be able to get functional range of motion. So at phase 2, our goals for range of motion is about 100 degrees total, okay? And so what I mean by that is depending on their limitations, remember we said that they oftentimes have limitations, you kind of want to think like 30 degrees, so 30 degrees from full extension, so 30 degrees from 0 to 130 degrees of flexion. That's an appropriate amount of range that you're looking for by about 8 weeks. And then for pronation and supination, you want to try to get from about 50 degrees of pronation to 50 degrees of supination. So all the way through those 2 movements on both sides, in both directions. And again, CPM, you're continuing with CPM if they're willing and they're tolerating it okay. This says 6 hours per day. If they can tolerate it 6 hours per day, I don't know if a lot of people can, but they can certainly try. We also want to teach them how to mobilize the scar and kind of do some soft tissue work on their own. And teach them how to figure out how to keep that arm from moving too much. Oftentimes they might put them in a brace or something. The doctor might put them in a brace. And so again, initially, those first couple weeks, you're really not moving the arm too much except for the CPM moving the arm. And then you're moving the shoulder and wrist. But when you get into the second phase, you can start having them do active range of motion, but not really doing ADLs with that side very much. So there again is that functional range of motion. That's what we're looking for a functional range of motion for this phase. And our treatment, active assisted range of motion, active range of motion, passive range of motion, all of those things. And you want to be doing this treatment at least 5 days per week, so a lot. And again, you're watching irritability, but you want them to be able to tolerate flexion, extension, but don't forget supination and pronation. All three of those movements are really, really important. And it's really important that you're focusing on that, those motions with all of these things: passive range of motion, active assisted, and active range of motion. You can also do some muscle isometrics at the wrist and shoulder. Be a little bit careful at the wrist if you're doing flexion, like wrist extension, wrist flexion, that you're not irritating around the elbow, because we know those tendons start at the elbow, but really you should be okay. Same thing with like shoulder flexion. Remember, the bicep tendon works with shoulder flexion, so just be a little bit careful that you're not irritating the elbow with that kind of movement. And then soft tissue work, myofascial release work, making sure the scar and any nerve irritability, that you're decreasing that irritability. The third phase is from about 8 weeks to 24 weeks. So it's kind of a long phase, and this is where we're really spending a lot of time on making sure they don't have pain. They really, hopefully at this point, don't have any pain. And we want them to really have full range of motion, again, within their own limits. So if there's still bone in there or whatever, we're not going to be able to push past that, but within limits, hopefully, that are functional. Grip, we're going to be focusing a lot on grip during this phase and starting to do more resisted range of motion. So grip is going to be important with elbow and shoulder movement. We want grip strength to be at least 75% of the compared to the uninvolved side. And wrist strength should be 75 to 80% of the uninvolved side. So we're really testing those things at this point to make sure that we're getting good functional improvement of the wrist and hand so that they can go back to their ADLs. So as they start to return to ADLs, it's important that they understand body mechanics, silly things, but it's surprising, especially women. We tend to move our wrist in really weird positions, which could really affect things like the extensor tendon at the elbow and cause a lot of irritability. And so it's important to practice ADLs as part of your treatment to make sure that they're doing those things in such a way that their wrist is essentially staying in neutral. So they're not going into too much wrist extension or flexion, any weird supination, pronation positions that might influence and irritate the elbow. So treatment during phase 3, again, we're starting to do more resistance. So hopefully we've been doing resistance at the shoulder and the wrist and hand, but now we're going to increase. We're going to really increase things like putty exercises, the grip exercises, focusing on some ADL training, and then at about 16 to 20 weeks, we can go back to work simulation. So work simulation also being ADL simulation, but if they do have to go back to a job that requires typing or a job that requires lifting or things like that, then you're going to start playing with those movements at about 4 months. And then the last phase is sport training. Again, this is just, you're going to try to make sure that their strength is within 80%, and that their range of motion is as good as it can be before you start getting back into return to sport and those things. So again, this is a relatively short one. It's kind of a strange problem though, and I will say that when you see it, you're going to probably see it non-operatively, and so you need to recognize when it's there. A lot of patients come to us with an x-ray and say, hey, look, I have this problem, and the doctor just wants me to get range of motion. And so you're doing that, but you're doing that without causing irritability. That's the big thing, is that you are making sure that they don't tell you that, oh my gosh, I had so much pain after your visit, because that means you did too much. But at the same time, you definitely want to try to improve their range of motion. Do soft tissue work to help with that, and then joint mobilization as much as you can.